Hi, since most of the information I used in my write-up and in my code are very quantitative and kind of describing how we can use bootstrapping, p-value, null hypothesis to show why a multiplier of 1.21 in the GFR algorithm is egregious, I want to talk more about the effects and the significance behind this project. The use of a race coefficient, a multiplier of 1.21 in the GFR algorithm, boosts Black kidney patients' GFR scores by an additional 15.9%, which causes them to appear much healthier than they actually are, even when they're not. The effects of this, as illustrated by Paul Eggers of Medicare and Medicaid Services, shows that although Black people constitute over 35% of all kidney failure patients and are 4 times more likely to develop kidney disease than white patients, they are 4 times less likely to receive a kidney transplant, even when all age, blood type, immunological, locational factors are excluded. In fact, last year, Tom Simonite of Wired Magazine reported that out of 57,000 kidney patients in Boston Hospital, 1/3 of Black patients would have been placed in critical care if their kidneys had been calculated with the same algorithm used for non-Black patients. The absence of change being made to establish equality in the GFR algorithm has also led to a similar trend in the way healthcare workers respond to the needs of Black kidney patients. The Agency for Healthcare Research and Quality reported that 40% of the quality measures were still worse for Black people than white people. This stereotype that the kidney algorithm is based on encourages biases already held amongst numerous healthcare workers, and it causes doctors to view Black people as inherently healthier and thus be less attentive towards them. So it's not only affecting kidney patients, but it's affecting all Black patients. And we see this in statistics throughout public health disparities in the medical field in America. This is a write-up that I wrote in high school when I was advocating against the GFR algorithm because it's an issue that's close to home. It's an issue that's close to our community. And I think it's very important that we talk about this, because it's one thing to use words and qualitative measurements, but I think what this class taught me is that it finally provided me with a way to quantitatively support my analysis, not just use other people's research, but also use my own quantitative analysis to say, hey, like, we actually shouldn't be using this. This is unethical. This is medically unethical. It's inhumane. And I think having been provided the tools to be able to do that through this class has been incredibly important for me and incredibly important for the way that I advocate for this issue moving forward. Thank you.